Hello, everybody, and welcome to the Hughes-Kluge stroke and acute intracranial problems. This is recording 2. And in recording 1, we talked about the ischemic stroke, and now let's talk about another intracranial problem, where you've got a 22-year-old construction worker who arrives in the emergency department complaining of the worst headache of his life. He denies any trauma or medical problems, and pretty much all of his vital signs and assessment is within normal limits. A Glasgow Coma scale is 15 and the pupils are equal and responsive to light. So what about his complaint causes concern to you? And what you should be thinking about is that any individual who complains about the worst headache of their life, you have to consider that this might be some kind of intracranial bleeding problem. And if you think recently there was a Game of Thrones actress that had an intracranial problem, and that was what her complaint was, that she had the worst headache, and that's why she sought care. Now, the other key thing to think about and remember is that no matter the type of intracranial problem, whether it's a stroke, whether it's a brain bleed, whether it's a tumor, whether it's meningitis, it doesn't really matter what the intracranial problem is. All patients with intracranial problems are at risk for developing an elevated ICP, and then that can cause an alteration in cerebral perfusion pressure, or CPP. And the brain is pretty complex. There's different spaces, which means there are different places that these problems can occur. And when we talk about bleeding, epidural and subdural bleeding, spaces that bleeding can occur inside the skull, those will be addressed during the trauma at the end of the semester. The ones we're really focusing on now are the subarachnoid bleeding and the intracerebral hemorrhage. Intracerebral hemorrhage is bleeding that occurs deep within the brain. It's usually a rupture from hypertension of the very, very small blood vessels that kind of really creep and seep into the deep, deep, deep part of the brain. And the key thing about hemorrhagic brain attacks is that they do occur less frequently, but they have a higher mortality rate. The other focus that we'll talk about in details towards the end of this presentation is subarachnoid hemorrhage. In other words, subarachnoid space that a blood vessel, commonly a cerebral aneurysm, has hemorrhaged or burst or ruptured. Now we go back to our 22-year-old construction worker, and he suddenly begins to vomit, and you turn his head to the side because you don't want him to aspirate because he's now less responsive. So what are your priority interventions, and what do these clinical manifestations, the vomiting and the decreasing LOC, indicate? Let's talk about the word priority interventions. And Dr. Reed will use that term quite frequently on the exam. Other terms that really mean the same thing, or what would the nurse do first? What would the nurse immediately do? What is the first intervention? What is the most important intervention? And whenever you hear any of these terms, priority, first, immediate, most important, you should think about ABC, because that's really the guide for the nurse. And ABC is a mnemonic that indicates you should look or assess problems or things about the airway, then breathing, then circulation. And I'm actually going to give you another letter, and that's D. And D stands for disability. So we're going to assess in an ABCD manner. And the reason why he may have these changing signs and symptoms is that the ICP is rising. And we talked about the fact that any intracranial problem can cause an elevation or increase in intracranial pressure. And this can cause him to have a decreasing level of consciousness, which means he's unable to protect his airways, such as what we saw if he vomits, or he's not going to be able to breathe very well. He can have hypoventilation and hypoxia from the fact that he's not breathing very often or with a very good rate. And that would also cause hypercapnic, which is a fancy way of saying CO2 retention. So that kind of addresses A and B. Now, I know that as a nurse, a student nurse, you're very smart and you have the ability to multitask, and you can assess levels of consciousness, airway, and breathing all at the same time. I know you can. However, not on an exam. On an exam, you have to separate out each action, and therefore you need to address airway and breathing separately. Sing your ABCs to remind yourself as you walk into an exam, to remind you that priority interventions are ABCs. Initiation of an IV line and assessing blood pressure. These are things that belong in the C, circulation category. I would like you to note his blood pressure and heart rate. We also see that his level of arousability is decreased. Now, where does LOC and pupils, where do they fall? Well, they fall on maybe a new letter that you're going to learn about in our course, in critical care course, and that's D for disability. So even though we're talking about intracranial problems, airway and breathing and circulation are still going to be important, and assessing level of consciousness and D, disability, will come after you assess airway, breathing, and circulation. And then, of course, what I have written in front of you are some different assessment findings as far as how he responds. So look at these, and then let's go to the Glasgow Coma Scale, and then you can indicate where you think he is. So when we talk about the Glasgow Coma Scale, we're talking about three major categories. That's the eye opening, and this individual opens his eyes and withdraws only to painful stimuli. So that's why he received a score of 2 points. Verbal response, he didn't respond with clarity. He only makes unidentifiable sounds, so 2 points for that. And then the motor response is he doesn't obey a command or purposeful movement. He really just withdraws from pain. So when we add those numbers up, we see that he is a Glasgow Coma Scale of 8. And there's a cutesy little saying that says if the Glasgow Coma Scale is 8 or less, then it's time to intubate. Now, what are we looking at when we see all these different assessment characteristics? Well, we know that any intracranial problem has a potential for causing an increase in intracranial pressure, or they're at risk for having an increased intracranial pressure. And on this slide are the manifestations or the signs and symptoms of how you tell whether your patient is having increased ICP. Now, manifestations, signs, and symptoms, these things on this slide are very important. You will be asked with 100% certainty about these manifestations, whether it's on critical care tests, ATI, or NCLEX. So this is very important for you to get. Now, I do have these in a particular order because there are certain things that are early indicators, such as a change in a level of consciousness. So that's why any patient with an intracranial problem, there is usually a healthcare provider has ordered how often the level of consciousness are to be assessed, because it's a very early sign, and so you can connect or catch things that could be happening very quickly. Vomiting without nausea is also another sign of increasing ICP. And then I have 3 assessment characteristics that indicate rising ICP that are kind of lumped together, because these 3 are known as Cushing's triad. And this is an ominous sign. If there is a widened pulse pressure, a bradycardia, and changes in the respiratory pattern, these indicate rising ICP, and they're all known together collectively as Cushing's triad. Well, let's first identify what does it mean to have a widened pulse pressure. So if your patient has a blood pressure of 120/80, pulse pressure is the difference between the diastole to systole. So 120/80, you would subtract 80 from 120, and you would get a value of 4, and that's the pulse pressure. So what would it mean to widen? Well, for the pulse pressure to widen, the systolic pressure would increase, and the diastolic would either stay the same or the diastolic would slightly fall. So that would mean that if you had 120/80, a widened pulse pressure would be a blood pressure that is for at perhaps 170/80 or 170/75. So the difference between diastolic, or you subtract diastolic from systolic, and that's your pulse pressure. Bradycardia is pretty self-explanatory, any heart rate that is less than 60. Changes in respiratory pattern is not so clear, and the respiratory rate. What do I mean by that? Well, it really could be a lot of things. It could be a diminished respiratory rate, or a rapid respiratory rate, or the pattern could be odd, such as maybe perhaps you remember something from your assessment course where we called it Cheyne-Stokes, where you have a very rapid accelerating respiratory rate followed by no respirations. You're not going to be asked about the specific naming of these different respiratory patterns. What you need to get from this is that the respiratory rate can be varied. It can be slow, it can be fast, it can be an abnormal pattern. And why is such a variation? Well, it totally depends on the portion of the brainstem that's affected. But a change in the respiratory rate and pattern and Cushing's triad really indicates to you, or should indicate to you, that your brainstem is being affected. What other signs and symptoms would you see? These are ocular pupil signs. When does that occur? Well, it's somewhat of a later sign, so therefore if you wait for the pupil to change or be bizarre, well, then you've missed the boat altogether and you put your patient at risk. What do I mean by pupil signs? Well, it could be that you have one pupil that's fixed and dilated, or one pupil is fixed and constricted, and then the other pupil is responding, or you could actually have both pupils fixed and dilated, or both pupils fixed and constricted. It really doesn't matter what the pupil sign is. You're just not going to see the normal pupil sign, which is PERLA, PERLA. Decreased motor function or abnormal posturing, that means if you elicit a pain response. So here's the order for your assessment. You would come in if the patient didn't open their eyes and respond to you just by the sound of you walking in, then you would call their name. If they still don't respond to you, well, then you would shake them and touch them and see if they would respond. And then, of course, if you don't elicit a response for any of the previous mentioned, then the next thing you're going to do is elicit a pain response. Now, what should the patient do when you give them pain? Well, at the very least, they should either pull away from you or reach over and slap you, but they shouldn't do what's known as decerebrate or discorticate posturing. So I've got pictures of these, or you can find pictures of these somewhere in the notes, but essentially what it means is that they do an abnormal and bizarre movement in response to pain. It is not normal to pull your hands up and into the body in response to a painful stimuli. The normality of a painful stimuli response is to move away from it. So now that you've identified the things that can indicate increasing ICP, what measures do you, the nurse, use to either prevent an ICP that is actually already elevated, or to prevent an ICP from becoming elevated? Because as we've mentioned several times, any intracranial problem, regardless of the type, places your patient at risk for rising ICP. Why do I say that so often? You must remember it. What about the nursing measures to prevent and manage ICP? These are known as the 8s of ICP management. And I am going to go through in a little bit of detail all of these. If you look at Elevate, I think that's pretty much understandable, but we really are specific with our Elevated. We want the head of the bed to be between 30 and 45 degrees. Why? Well, when we talked about intracranial pressure, we had defined that there were 3 subjects or odd things that were consisted of the intracranial pressure, and that's brain, blood, and CSF. And the Elevate is simply a measurement or a management of blood. We want arterial blood to flow up, but we want venous blood to flow down and out. And that's why we keep the head of the bed elevated 45 degrees, because it promotes venous outflow. We do not want to raise the head of the bed greater than 60. So could you have a patient at 30 to 60? Sure, you can. Anywhere in that range, never higher than 60. Why not higher than 60? Well, I want you to go over to a chair and bend from the belly over into a chair, and you can see or feel that you're putting pressure on your abdominal area. And intra-abdominal pressure, increased intra-abdominal pressure, can actually cause a reflex of that can cause the intracranial pressure to elevate. So we don't want the head of the bed ever over 60. Now, as with all things in critical care, there are exceptions to the rules. So what would that rule be? When would you not want your patient's head of the bed to be elevated? Well, let's say that the patient's blood pressure is very low, so it's marginally low. And you raise the head of the bed to 30 and the blood pressure goes down even further. So I've talked to you about the fact that CPP, cerebral perfusion pressure, is mathematical formula which includes the blood pressure. And so if you cause the blood pressure to markedly go down as a result of elevating the head of the bed, well, we can't have that because then that puts the patient in jeopardy. So you don't want to raise the head of the bed when the blood pressure is already low, and that when it goes down even further when the head of the bed goes up. If you have problems with this, then be sure and email me. What about the other 8? Straight, keep the neck straight to promote venous downflow or outflow from the head. We want to regulate, keep the blood pressure in normal ranges. You will not be asked what range to keep it in. That's a physician decision as to what orders to keep the blood pressure. What will you be asked about the blood pressure? This is important. Write this down. Dr. Reed's marker of blood pressure management is to ensure that the systolic blood pressure is 90 or above and that the MAP is 70 or above. If you do not have either of those two things, then the blood pressure is not regulated or managed. Separate, space out stressful activities. Do not cluster care. In other words, you're going to be bugging your patient all day long because you want to go in, do one thing, walk out. And the reason for this is that if you do a bunch of care at one time, even though it seems like it would make the patient annoyed and tired, the object is not to increase the ICP by making them annoyed by doing a lot of things at one time. So again, separate, space out stressful activities. Intubate. We want to protect the airway because a patient with altered levels of consciousness cannot protect their own airway. Now, I do say intubate, but I don't mean nurse intubate unless you're a CRNA. Intubate means prepare for intubation. Identify to the physician that your patient's not able to manage their airway and make a recommendation that, I think this patient needs to be intubated, or if your patient's not breathing in an adequate amount. Coagulate. Check the PT-PTT. We don't necessarily want the blood too thin, especially if you have a hemorrhagic bleed, but we definitely don't want it too thick. So again, this is keeping that nice balance with proper coagulation. Medicate. Medicate is, again, another general term. There's several different medications that we're going to use. We'll talk about some of those in detail later, such as the seizure meds, anti-seizure meds, corticosteroids. Let's talk about the two now, and that's mannitol. Mannitol is a hyperosmotic diuretic. So what does that mean? It means when you give mannitol that because it's hyperosmolar, it will draw fluid out of the brain cell. Again, if you recall, increasing or a lack of oxygen and problems with intracranial problems cause the brain cell to swell, and so we want to reduce that swelling. And not only can we pull or draw water out with a hyperosmolar diuretic, but because it's a diuretic, it'll get rid of that excess fluid. H2 receptor blockers, we know that patients in the hospital are stressed with any kind of illness. We don't want them to develop an ulcer. Hyperventilate. Now this is an important concept, and it can be kind of confusing. So we know normally that if a patient's or that normal CO2 management is between 35 and 45, and that CO2 in and of itself, it's an acid and it can affect the pH. Well, the problem can be with patients who have intracranial problems and rising ICP. If all of these previous mentioned measures are not managing the ICP, in fact, the ICP continues to go up, then the physician may do a maneuver called hyperventilation. Now, this cannot be done unless the patient's on a ventilator. And of course, any patient with horribly elevated ICP will likely be on a ventilator because they're going to manage them in that manner, or they're not breathing at all. And when the patient has the prescription of hyperventilation, the physician will want to keep the CO2 at a lower level. Now, in our course, we've had it very specific. The PCO2 should be kept between 25 and 35. Again, normal is 35 to 45. So what does this help? Well, increased CO2 will cause cerebral vasodilation. So not necessarily body dilation below the head, but cerebral vasodilation. So how is that a problem? How does that cause rising ICP? Well, if you think about it again, we think about the components of what's in the head, and we know that blood is one of the ingredients that's in the head that makes up intracranial pressure. And if there's a lot more blood in the head because of cerebral blood vessel vasodilation, then that could increase the ICP. Here's the problem of why the number is very specific. If we do cause hyperventilation and we drop the CO2 too low, as in our course, that would be less than 25, well, then you can cause a profound cerebral vasoconstriction. And we know that there is a problem with perfusion, as in blood flow delivery to the brain cells. And if we profoundly vasoconstrict the cerebral blood vessel, then we could actually cause the problem of ischemia. In other words, we need it 25 to 35 so that we have that just right blood vessel balance between vasodilation and vasoconstriction. Evacuate. Evacuate is remove CSF via the ventriculostomy, and then operate surgical evacuation is frequently needed if there's bleeding in the brain, if this is an intracerebral hemorrhage or some kind of subarachnoid hemorrhage, and if there's a clot or a tumor. Again, you're not going to be the one, you're not going to be asked, well, hey, does this patient need an operation? That's a physician decision, but you just need to be aware that one of the aids of ICP management is to evacuate things that are in the head and taking up space. What are the consequences or the problems that can occur because of a rise in ICP? Again, if you look at this picture, I think it really does say it all. If the ICP is elevated, then you know that because the skull is a hard bony prominence, there's nowhere for the brain to go. And that increase in cerebral pressure, intracerebral pressure, or intracranial pressure, can cause a problem with the allowance of arterial blood to perfuse up and deliver O2. And this can result in cerebral blood volume and edema because of rising ICP. But really, for your purposes, you just have to realize that if the ICP goes up, perfusion can fall, and this can lead to ischemia and brain infarction. Now, I do want to define for you the difference between these two terms. Likely you know, but just to make sure. So when we talk about the term ischemia, ischemia means that the cell has less O2 than what the cell would need or would like. And therefore, ischemia can be reversed, or the problems can be halted if you just deliver enough O2. Whereas if the brain cell infarcts means to die, and it means to die because of a lack of oxygen delivery by the blood vessel. Once a brain cell has died, it's gone, it's dead, and it cannot be resuscitated. Think of ischemia as less than O2 than is what's needed or wanted, and this is a reversible scenario. So that's where the prevention measures is to prevent ischemia. The neurosurgeon inserts a ventriculostomy to monitor and manage ICP and CPP. So what is it? Well, that's essentially the neurosurgeon will drill a hole through the skull and put this bolt down in the ventricle. And then with this little gadget here, we can measure intracranial pressure. So it's a way to really directly measure the intracranial pressure so that we don't necessarily rely on our assessment findings and think, well, we think the intracranial pressure is high. We with this ventriculostomy, we know whether the intracranial pressure is high, and we can manage it. So when you look at this assessment data, we see the heart rate, the blood pressure, and that the ICP is markedly elevated. Again, 5 to 15 is normal. So what nursing intervention is needed? Well, that's the other purpose of putting the ventriculostomy in. Not only can we directly measure intracranial pressure, but we can also drain the CSF. So that's the evacuate part, the evacuate. So this will allow the nurse, once elevation in ICP is noted, then the nurse can drain the ICP. And the reasoning for that is, again, we have our three things in the head: blood, CSF, and brain. And when there's an elevation in intracranial pressure, we really don't want to drain out blood because we need blood to carry oxygen around. And then we don't really want to drain out brain, because we want the brain to stay in the head. And so the only thing that we can really manipulate to get the ICP value down is the CSF. And so evacuate CSF fluid. If you have any questions, let me know. We'll move on to 3 in just a moment.